Good morning, colleagues. Can you hear me, David?
Very well, thank you.
Okay. Welcome to the WHO and Vital Strategies warm-up session. And the subject of this session is the health sector and CRVS, or more clearly, it's the role of the health sector in CRVS system strengthening. My name is Aza Badr, and I'm leading WHO's efforts to strengthen CRVS systems from the WHO headquarters in Geneva. I will be moderating this warm-up session today. It is now 45 a.m. in Geneva, and the temperature outside is 5 centigrades. So warm-up session is due in time. We are celebrating this warm-up session with 5 WHO colleagues joining from 4 WHO regional offices, in addition to our Health Data Collaborative colleague, also joining from Geneva. The main message that we wish to convey today is that the health sector needs to play a stronger role in CRVS strengthening. The health sector needs to notify all vital events that take place in health facilities and the communities to the Ministry of Health and to the civil registration authorities. This is noting that most births, more than 70% globally, and more than 50% of death take place in health facilities. In addition, birth and death that take place in the community are assisted by health workers or are known to community health workers who report to the health sector. Strengthened health sector notification is one of the strategic objectives of the WHO Strategic Implementation Plan, which was launched earlier this year. Now let us watch this short movie to introduce us to the WHO CRVS Strategic Implementation Plan.
A well-functioning civil registration and vital statistics system, better known as CRVS, uses inputs into and exits from a population register to provide governments with critical information on the population by age, sex, and location on which to develop policies and plan services. Good public health decision-making requires timely, reliable, and actionable data on births and deaths, including cause of death, collected through these systems. A well-functioning CRVS system is the best source of data for measuring 67 of the 231 SDG indicators, including the health-related SDG 3. The main challenge that remains is that few low and middle-income countries have systems that produce cause-of-death statistics of sufficient quality to guide public health decision-making. Only about one-third of countries, representing about 25% of the world's population, regularly produce cause-of-death data through CRVS systems which are of sufficient quality to support policy action, mostly in Europe and the Americas. A further third of countries, representing about 50 to 55% of the world's population, produce lower quality cause-of-death data with significant biases, while another third of countries lack such data altogether. Overall, only about two-thirds of the 55 million annual deaths worldwide are registered or notified to CRVS systems, and of these, up to half are either not assigned a cause of death or are assigned an ill-defined or intermediate cause, which is of limited public health value. According to the 2020 SCORE Global Report, from 133 countries, 44% have either a nascent or limited capacity to count births, deaths, and causes of deaths. SCORE also found that although most countries in Europe and the Americas have universal death registration, this number falls to 61% in Southeast Asia and only 10% in Africa. This highlights the urgent need to invest in all aspects of CRVS system strengthening. In a public health emergency such as COVID-19, basic CRVS processes including birth and death notification, registration, and mortality coding are vital to inform and support both national and global responses as well as up-to-date monitoring of the spread of fatalities. In its commitment to address data gaps and support the strengthening of national CRVS systems, WHO has, together with partners, developed the WHO CRVS Strategic Implementation Plan 2021 to 2025. The strategic plan is heavily evidence-based and draws on the findings and evaluation of the application of several years of CRVS interventions and research in countries. The aim of the WHO CRVS Strategic Implementation Plan is to empower member states to more effectively mobilize their health sector to lead or contribute to CRVS system strengthening efforts in order to ensure maximum benefit from routine data systems for policy and development. The health sector has an important role to play in strengthening CRVS systems. Linking the health sector to civil registration will facilitate timely birth and death notification and more accurate information on causes of death. CRVS partners are encouraged to join forces towards the operationalization of the WHO CRVS Strategic Implementation Plan so that together, everyone is counted, because everyone counts.
Thank you very much. And now we're going to have our representatives from the regional offices take the floor and explain all the respective efforts of the WHO regional offices. So I give the floor to Dr. Iman Ali, Technical Officer, Health Information Systems from the WHO Eastern Mediterranean Regional Office based in Cairo, who will present an overall view of AMRO's efforts and the role of the health sector in improving CRVS systems in the region. Over to Iman.
Thank you so much, Dr. Azza, and very early good morning from here in Eastern Mediterranean region. I'm Dr. Iman Ali. I'm Technical Officer Health Information System in Eastern Mediterranean Regional Office based in Cairo. And I thank you all for your participation and thank you for inviting me to join this session. Actually, as Dr. Azza mentioned, and as you have seen in the video, the role of health sector is very remarkable in CRVS and the registration of diseases, and mainly in causes of disease. And in order to summarize our role in the regional office to support this function in CRVS system, bear the role of health sector, we need to focus somehow to the situation in the countries and the issues that encounter the timely and accurate registration of this, and mainly causes of this. In general, countries in our region doing better in birth registration than this registration, and they are doing better in this registration than cause of this registration. And actually, this is because of several issues, and one of them is the active role of family members in transferring data between primary level health facility to central level to register cause of this. And this actually cause a lot of delay and loss of data to register. And this happened due to lack of digital electronic information system capacities in the countries to collect data and transfer data and create a smooth flow of data between health facilities and data management center in country level. So from observation of the country, civil registration office and its role to develop official death certificate and counting these events have, and the legal aspect of this function support that better availability of data in terms of counting diseases. But when we look from health institution role and health institution, we found a gap, big gap in registering causes of this. And in our region, we find that this cause of this registration, very few countries achieve the 80% coverage of cause of this registration, and even if when we work on this data, we found that the quality is limited due to inaccuracy and incompleteness of cause of this registration. So identification of the challenges and identifying country-specific challenges help to develop the plan to support and improve the this registration with particular focus on cause of this registration in health sector. In general, there are common challenges which known, but there is also country-specific challenges. And as I mentioned, IT capacity and staff turnover and the understanding of appropriate writing of this certification are among these common challenges that happen and frequently observed in country. Among the challenges also the multi-sectoral coordination at national level. Although we have shown great example of coordination and cooperation between partners and sector at regional and global level, however, still at national level there are a gap in this in building and establishing a mechanism of communication and coordination between different sectors. We also need to highlight that the timely need for reporting on cause of this in context of COVID is now one of the major challenge and major issue, because we are shifting the team who's used to compile the data on annual basis, but now with pandemic occurrence and the need for timely data, we are investing on the timely reporting and total this registration and the analysis of causes as much as possible on a weekly and monthly basis. So the emergence of surveillance concept on routine health information system is among our mandate of work as well, to support the cause of this registration and to enhance the quality of case of this registration. So there are four dimensions of work and 4 domain of work. One of them, the first one is improving completeness and coverage and the quality of this and cause of this registration and data use. The second is improve the timely and surveillance of total disease by age and sex distribution to provide the epidemiological information of data that support the understanding of evolution of COVID pandemic and also support expectation of the waves and the progression of the pandemic. The third aspect is supporting the standard and implementation of Family of International Classification of Disease, the ICD-11, and other classifications that improve the understanding of cause of this and the health system intervention for causes of this. And lastly, to maintain and to scale up the coordination, invest on the coordination between partners at all levels, at national, regional, and global level. Training, very quickly, for cause of this registration, as mentioned, the electronic certification is among the important initiative and the important support activity, as well as training on writing the underlying cause of this and identifying the underlying cause of this through the use of a standard and the global WHO this certificate 2016. Analysis of mortality, total mortality data on weekly and monthly basis. This actually require an active data collection system, and this is considered a new concept for the countries and for health information system teams who's used to use the data on monthly and annual basis. However, establishing a surveillance system in hospital, in pilot hospital, and train the data manager and data collectors to send the data on weekly basis to develop the epi curve of total disease to help interpretation of epidemic curve of COVID-19 and also for any other epidemics. For family of international classification of disease, the coding of cause of death with ICD-10 is still challenging. However, we are moving to ICD-11, but still it is a challenging and an important area of work for several countries who's having a small-scale electronic information system. With pilot implementation of ICD-11 for 5 countries in our region, and for UNRWA as in morbidity registration system. So, and lastly, the coordination, as mentioned, several coordination now is running with United Nations Economic Commission for West Asia to build the capacity on quality of civil registration data, in addition to finalize the registration, the civil CRVS strategy for the Arab countries, along with different coordination initiative with African CDC, with UNICA, and with UN ESCAP. This is summarizing the initiative based on the situation in our region. And I stop here. Over to you, Dr. Az.
Thank you very much, Iman. That was excellent. And over to Dr. Karapet Davitian, Technical Officer from the European Regional Office. He's based in Copenhagen, and who will present an overview of Euro's efforts and the role of the health sector in improving CRVS system in the European region. Over to you, Karapet.
Thank you very much, Dr. Raza. Dear colleagues, good morning, good afternoon, or good evening, depending on where you are based now. It's a pleasure to be here with you. My name is Karapet Davsan, and I'm Technical Officer of Health Information Systems from the Unit of Data Metrics and Analytics, Division of Country Health Policies and Systems. First of all, I'd like to thank you organizers for the opportunity to participate and present about CRVS from the perspectives of health information systems in WHO European region, which includes 53 recognized countries and territories and serves near to 1 billion population. Why I'm saying from the perspectives of health information systems, because our information mainly about CRVS systems and particularly digitalization based on the health information system assessments, part of which is this CRVS as one of the most important part of health information systems. As you can assume, there are many countries in our region with a different stage of CRVS development, and I believe the existing problems are probably common and similar to other regions. Similarly, there are good examples of CRVS development. These are mainly thanks to ongoing digitalization efforts and integration efforts of health information system, which are positively reflected on CRVS systems. And we can definitely say that these efforts were enhanced or empowered also thanks to the pandemic, in order to improve data quality, efficiency of data collection efforts, and of course, in order to improve timeliness of data and support decision making. In general, the countries under EU regulations or where there is national identifiers have a higher quality CRVS data, and the integration is much efficient and usually implemented at least in some extent. So there are great examples of a CRVS system in place which could be considered as best practices from the point of view being integrated or digitalized. However, it is also important to highlight the best practices of being proactive, or in other words, best practices from the point of view of being able to make big changes. In this making big changes in this area and making significant progress for generating data. In this regards, there are examples of huge progress, and this is also thanks to COVID, which forced digitalization and generating actionable data. The pandemic also required eventually to deal with or to consider the gaps and discrepancies between CRVS systems and parallel reporting systems through the medical institutions or reporting channels. Regarding the further CRVS development, I'd like to highlight the perspectives related to particularly to the ICD-11 implementation. It is obvious that the digitalization of health information systems, its further integration with CRVS and implementation of ICD-11 will significantly improve the accuracy and detalization of mortality and morbidity data. This means the ICD-11 implementation and preparation must be top priority now. In this regards, this year we established WHO Family of International Classifications European Regional Network to support the development, implementation, and maintenance of WHO Family of International Classifications across the European region and through the global network. Our work for ICD-11 implementation includes promotion, preparation for translation, and guiding through the implementation process. For some countries, we even providing financial support thanks to donors, of course. We are conducting ICD-11 implementation and introduction preparation workshops. This year we implemented such kind of workshops for Central Asia region, which is priority area for us. However, since 2019, overall 25 countries already participated in such kind of workshops, which is near to 50% of countries in our region. Trying to summarize shortly about the status or situation of CRVS in our region, we can describe the current status of CRVS system in WHO European region as ongoing development and in different stages of development depending on the sub-regions and countries, as well as countries' socioeconomic status. Definitely, there are achievements and CRVS data, mainly thanks to digitalization of health information system and its integration with CRVS. However, these efforts require continuous support and further development. It is also worth to highlight the importance of continuous capacity building for human resource development to ensure continuity of the ongoing work and particularly improving quality of mortality and morbidity data, coding cause of death, and as I told, ensuring continuity of the work. So these are the main highlights from my side, and thank you all for your attention. Back to you, Dr. Azza.
Thank you very much, Karpet. That was really great. And now we will take you on a short journey through a short movie that depicts the role of the health sector in CRVS system strengthening.
As a global steward of public health data, WHO is committed to upholding the highest standards of civil registration and vital statistics systems, including the production of data on births, deaths, and causes of death. Yet, too many countries still lack this basic information, and too many people still live without access to essential services guaranteed by birth and death certificates. The COVID-19 pandemic has underscored the urgent need for timely, reliable, and actionable civil registration and vital statistics, or CRVS, data to guide emergency response and drive strategic policy design. In a public health emergency such as COVID-19, basic CRVS processes, including birth and death notification, registration, and mortality coding, are vital to inform and support both national and global responses, as well as up-to-date monitoring of the spread of fatalities. High-quality CRVS data are also critical to measure and track population health outcomes, determinants, and health inequalities. This information supports decision makers to develop and implement equity-oriented policies and allocate resources more effectively. The health sector plays an important role in strengthening CRVS systems. By linking the health sector to the civil registration, governments can better facilitate timely birth and death notification and ensure more accurate information on causes of death. The health sector has a wide network of healthcare staff who are in frequent contact with people throughout the most critical moments in their lives: pregnancy, birth, childhood, adolescence, adulthood, and death. Reproductive, maternal, newborn, and child health services are a significant opportunity to capture births and deaths. For example, by utilizing high immunization coverage to notify births to the civil registry that are not reported through the routine system, or by linking CRVS with maternal and child death surveillance systems. For the purposes of health statistics, information from disease-specific surveillance programs such as HIV, AIDS, tuberculosis, and malaria, as well as from cancer registries and other non-communicable disease surveillance programs, can and should be used to improve mortality data for specific diseases. External causes of death data can also be improved from coronial inquiries and mortuaries. Such information is typically not integrated back into the routine CRVS system. This leads to discrepancies and inaccurate results on which to build and evaluate policies for disease and, in particular, injury control. For some important causes of death, such as road traffic accidents, integrating relevant information from police reports and the health sector can significantly improve the accuracy and hence the policy relevance of cause of death data for these events. The challenge is that few low and middle income countries have CRVS systems that produce cause of death statistics of sufficient quality to guide public health decision making. This highlights the urgent need to invest in all aspects of CRVS system strengthening. COVID-19 has clearly shown that CRVS systems are a cornerstone of strong health systems for the future. With every crisis comes an opportunity, and COVID-19 is a unique window to address these long-standing gaps once and for all. In its commitment to support member states with health information system strengthening, WHO has, together with partners, developed the WHO CRVS Strategic Implementation Plan 2021 to 2025. In addition, WHO
A well-functioning civil registration and vital statistics system, better known as CRVS, uses inputs into and exits from a population register to provide governments with
Apologies for the technical glitch there. We just, if possible, to end the movie from your side, ESCAP. If not, we can go to the session. Okay, so anyway, let me tell you the end part of the movie. The end part of the movie is a call for universal civil registration for universal health coverage. So WHO is calling for universal civil registration for universal health coverage, noting that it is not possible to reach every child with health care services and every adolescent and every adult without universal civil registration. And so now I give the floor to Dr. Manoj Jahalahani, Director of Health Information Systems from the Southeast Asia Regional Office based in New Delhi, who will present an overview of CRO's efforts and the role of the health sector in improving CRVS systems in the region. Over to you, Dr. Manoj.
Thanks, Ezra. Can you hear me well?
Loud and clear.
Thank you. So in 2014, a 67th session of the Regional Committee of WHO Southeast Asia region adopted a resolution on improving CRVS The regional strategy on CRVS was also adopted in 2014, which focused on the health sector initiatives at the regional, national, and local levels to support notification and universal civil registration of births and deaths and improve production of accurate, complete, and timely vital statistics, including causes of death. The goals and indicators of the SEER regional strategy were aligned with the regional action framework for CRVS in Asia and the Pacific developed through the UN ESCAP. As the short film just showed, we need to recognize the win-win-win partnership between the health systems, the CRVS systems, and the citizens. The health system functionaries are in touch with almost all the pregnant women since they render ANC care, including required vaccines, particularly in rural areas, and therefore are fully aware of the pregnancy outcomes. They are also in regular touch with almost all the families and aware of all the births and deaths, even if the births and deaths don't occur in health facilities, since these most fundamental events are socially very visible events and known to government field functionaries of health department and community health workers. The birth and death data and cause of death data are of utmost value to the health department to plan their services, decide their priorities and program based on fertility and disease burden, and to track progress of their initiatives on several SDG indicators. So accurate, complete, and timely vital statistics is of great value to the health department. It also has huge benefits to the community, citizens, including having access to all the services and benefits besides the legal identity. Ensuring proactively close collaboration between the health department and the CRVS system can therefore give great boost to the notification and CRVS registration, including cause of death registration, and improve access to needed services for the families. This is now also easily facilitated by the use of IT and digital technologies. For example, state of Tamil Nadu in India has ensured that all the births that come to the notice of health department are notified to the CRVS system and vice versa using the technology, ensuring 100% registration of all births in the CRVS system and improving reach of all the needed services to the beneficiaries by the health department. Now, following the first ministerial conference, WHO SEER supported a number of countries in the region. First, it helped undertake rapid and comprehensive assessments of their CRVS systems. Then it helped develop strategic action plans, and it also provided implementation support, particularly in registering causes of death. Continuous technical support was also provided to member countries in strengthening ICD coding and verbal autopsy to improve cause of death statistics. At present, all member states, excepting India, have completed comprehensive assessment. In order to improve cause of death statistics, WHO CRO first focused upon capacity building and ICD among the member states. Further, to improve the cause of death statistics, WHO designed the standard international reporting form of cause of death and recommended and supported to all member states to use the same to bring international comparability among the member states. In 2016, WHO developed a DHIS2 based tool called Startup List of Mortality, which covers approximately 120 cause of deaths that cover around 80% of all causes recorded by the member states and supported its implementation. In Bangladesh, the said tool was successfully implemented in around 140 major health facilities. In 2020, WHO CRO again undertook a review to assess progress in CR countries on CRVS development during 2015 to 2019 and planned the next steps to accelerate system strengthening activities in all countries. As we recognize, CRVS systems vary greatly with different policy perspectives and administrative structures in different countries. So meeting the needs of this diversity of countries and the variations in current operational status of national CRVS system necessitated a country-specific approach to CRVS system strengthening. Accordingly, in 2020, the regional office partnered with Vital Strategies to formulate a CRVS improvement project designed to provide technical support tailored to the specific needs of the countries in the region. And with this approach, we've initiated a program to support the registration deficient countries, Bangladesh, Bhutan, India, Indonesia, Myanmar, Nepal, and Timor-Leste in strengthening their CRVS systems. 4 of these countries have already established their country teams who are leading the work of CRVS improvement in their respective countries. And WHO, in collaboration with other in-country development partners, is assisting the country teams in systematically assessing, analyzing, and redesigning their CRVS systems following a holistic and process-centric approach. The tools and methods being used are aligned to the UN concepts and methods and international best practices. Learning from the successful example, these countries are designing proactive processes by leveraging the health sector for ensuring complete registration and efficient delivery of services. WHO CRO has also initiated activities to prepare certain normative documents and training tools to support implementation of medical certification of causes of death. Currently, we're supporting the countries in building capacities on ICD-11 and helping them to transition from ICD-10 to ICD-11. And not only that, to get improved accuracy in cause of death, we have developed another DHIS2 based tool embedded with ICD-11, and we are supporting the member states in implementing the same, which should help the coders get the mortality coding and also save time. This piloting of this tool is planned in Maldives and Nepal next year. WHO CRO has been able to successfully improve the capacity of relevant country staff for all countries through orientation and training. We've used the online course of the World Bank and also through webinars on sharing of experiences from countries within the region and beyond. The countries clearly recognize the need to move from a passive system of registration to a more proactive system. They all recognize that it will be extremely crucial to leverage the health sector to improve CRBS. The strategies are well aligned to the strategic objectives included in the recently launched WHO Global Strategic Implementation Plan 2021-2025. In 2021, WHO and UNICEF have jointly launched an operational guidance document detailing how health institutions and health workers can support health-related program managers and civil registrars to strengthen CRVS systems to achieve universal registration of births, deaths, stillbirths, and causes of death. The WHO Strategic Implementation Plan 2021-25 and these operational guidance will form the basis for the future work of WHOCR for improvement of CRVS systems. Thank you for this opportunity and patience. Over to you, Eza.
Thank you very much, Dr. Manoj. Thank you very much also for reminding them of the WHO Strategic Implementation Plan. Thank you again. And now we move to Dr. Duan, Dr. Mingguan Duan, Technical Officer, Health Information Systems from the Western Pacific Regional Office. She is based in Manila, and she will present now an overview of WEPRO's efforts and the role of the health sector in improving CRVS systems in the region. Over to you, Duan.
Thank you, Ada. Please let me know whether you can see my screen now. I'm sharing my screen.
We can see it very well. Go ahead.
Okay, thanks, Ada. So first of all, I'd like to thank you and welcome all the participants for this session. And thanks a lot for offering me this opportunity to introduce you the WEPRO's efforts and the role of health sector in improving service system in our region. I'm Duan, the Technical Officer in Health Information and the Innovation Unit, Data Strategy and Innovation Team of WHO Western Pacific Regional Office. So basically, our region is quite diverse. We totally covering 37 member states and area in the region. The CRVS system in the region is actually at a reasonable level based on the score assessment, which conducted last year, with 91% of birth registration and 82% of death registration. However, as I mentioned, our region covering more than 30 member states and areas. The region is quite diverse. You can observe from the figure on your right hand, the death registration and the completeness of causes of death are ranged from nearly over 9% in several countries, but still far less than 50% in other countries. So similarly, as other speakers already shared with you the challenges, WEPRO is facing the similar challenges, and based on our internal rapid survey conducted at the beginning of this year, we noticed that there are multiple death registration systems in countries, not only CRVS. So the fragmented information are existing and with very limited sharing and interoperability. Also, the completeness of death and birth registration are quite diverse and varies from countries to country. Similarly, on timeliness, delay of reporting, notification, quality of cause of death data, similarly as well for the data availability issue and accessibility issue. However, our region has been working really hard to improve and solve those problems. So I already listed some activities is ongoing currently in our member states, of course, together with WebPro's efforts. So our member states are really trying hard to promote multi-sector collaboration. For example, in one of our member states at the city level, they achieved three-system integration and incorporation. So they combined the information system for birth registration and immunization management information system, as well as the students' registration information system at their level to save lots of efforts for the three ministers as well as the parents' time of the students. Although it's not achieved at national level yet, but already piloted in several city level. And as of course, as mentioned by our colleagues in other regions, COVID-19 actually promoted communications and collaborations among different sectors. And also at the same time, we continue our efforts on system improvement and strengthening. Currently, CRVS system assessment are ongoing in 2 of our member states. And also we are actively promoting or exploring some tailored approaches inside of our country to really improve the death registration as well as all cause of death monitoring. Some of the member states are starting to involve community. Some of other member states start to communicate with funeral facilities. And also in our region, we have at least 6 countries have started to explore the approaches on ICD-11 transition. We have been conducted trainings and workshops for more than 3 member states in the region. And the third point is about the time list, which is the biggest headache for all of us who are being working in this area. However, based on our internal rapid survey, we even most of the countries, the target countries are middle and low income countries. Actually, they can achieve very timely death reporting at local level, which means not national level, but subnational level at local level. They can achieve even monthly or weekly or even real-time death reporting. And also we observe that most of the countries, they have completed or at least partially that electronic system inside of their country. And also for COVID-19 response, we have at least 6 countries in the region with weekly and monthly all cause of death data publicly available, while at least 4 additional countries are actively monitoring all cause of death and excess deaths by week and month since 2020. So as I already mentioned, WebPro spent lots of efforts and together with our member states to improve CRVS system by contributing from health sector level. As I already mentioned, we keep providing tailored country supports in previous slides. Meanwhile, we also developed several tools which can support our member states to move this work more efficiently. One of the delivery is our excess mortality calculator. So with this calculator, our users can simply calculate the expected deaths without really running the complicated code for the statistical models. And meanwhile, they can also keep the privacy. Basically, the results and the plots, the figures can only be saved and observed by the user themselves without sharing with anyone due to the sensitivity of those numbers. And also we developed the all cause of death mortality dashboard, which can monitoring weekly and monthly trend of all cause of death and excess mortality in the region. So here is the screenshot of our calculator, and also really happy to share. We heard not only WebPro member states are using it, it's also being expanded to other regions as well. And also we embedded our mortality dashboard here. After you click it, you can simply observe the trend of all cause of death mortality by week or by month. So after talking lots of efforts, what we will continue in next step is we will continue to promote the cross-sectional collaboration, continue to promote CRVS system strengthening through system interpretation and integration, and of course, exploring other innovative approaches. We will promote strategically using CRVS data as well as promoting ACM and excess mortality monitoring as part of multi-source surveillance for public health events response, similar such as COVID-19, as well as other policy making. We will summarize and share our field experiences and story in the region to other countries. We will continue to promote strategic and integrated capacity building, including but not limited to traditional trainings. So that's all from WebPro. Back to you, Azza.
Thank you very much, Duan. That was really comprehensive. And now we have, last but not least, our very own staff member in Geneva, consultant Dr. Mwenya Kasonde, who is consultant for the Health Data Collaborative, and she will present the role of the Health Data Collaborative in improving the CRVS systems among Health Data Collaborative partners. Over to you, Mwenya.
Thank you, Azza. Good morning, good afternoon, good evening, colleagues. I think it's appropriate to aim this very important conversation with a presentation on the Health Data Collaborative, speaking about the power of partnership, because of course, everything that we do and that we've discussed here today would not be possible without all of our partners. And since its inception in 2016, the Health Data Collaborative has provided a partnership foundation for stakeholders from 7 different constituencies to provide alternative solutions to problems by leveraging political, technical, and financial resources, as well as share good practices in support for country health information systems and CRVS systems. Especially important for leaving no one behind, especially in the SDG agenda, are research in academia, civil society, and the private sector. The Health Data Collaborative aims to align resources with country-identified priorities, and this is in order to decrease fragmentation, increase efficiency, and reduce the reporting burden that many of our health workers unfortunately go through. We emphasize at all times the country-led approaches throughout our regions. Many countries have shown great leadership in the Health Data Collaborative and have identified their own data, digital, and CRVS priorities. And this needs builds on existing coordination mechanisms in each region as key to supporting this country leadership. So overall, the HTC has 3 specific objectives. The first is to strengthen country health information systems, including CRVS systems. The second objective is to align partner resources with country-led data and digital priorities. And third, the Health Data Collaborative aims to identify and adapt global tools to local contexts. It's important to acknowledge country leadership in all that we do. This is key to transformation of health information systems and CRVS systems with all partners, and this is only possible with great political will and political leadership within the countries that we serve. The HDC has really grown over the years. From 2019, where we had only 52 members, we are now at over 300 members of individuals representing approximately 80 different organizations. And this power of the partnerships working together is a true asset to the countries that we support. The Health Data Collaborative provides a knowledge brokering role through webinars, as well as the website and working groups, and with the countries and constituencies together being able to share good practices. The Health Data Collaborative makes explicit links between data and use of data for health outcomes, especially in primary healthcare and of course, including CRVS. The biggest challenge does remain in terms of aligning resources with partner identified priorities. In CRVS specifically, the CRVS working group of the HDC is one of our key technical arms, and the working group aims to support coordinated country-level engagement with respective institutions, and this is consistent with the WHO CRVS global strategy, as well as respective partner agendas. The CRVS working group of the HDC also explores and leverages opportunities to accelerate the improvement of CRVS systems globally. It promotes the importance of CRVS in the global development agenda, and the group also acts as a liaison for information exchange between the HDC and other global and regional entities supporting CRVS strengthening. and to give a specific country example of some of the things that are going on in countries through the Health Data Collaborative partners. In Kenya, for example, different partners have supported mobile outreach programs in hard-to-reach and remote areas. As well as this, there's been support towards different policy implementation. As an example, the demand for birth certification being a requirement for school enrollment. Also in Kenya, there's been support towards rapid mortality surveillance, collaborating with the Ministry of Health, as well as other line ministries such as the Ministry of Interior and HTC partners. A key milestone has been implementing rapid mortality surveillance and determining excess mortality during the COVID-19 pandemic, and also supporting development of medical certification of cause of death app in the Kenya Health Information Systems for reporting mortality during RMS ongoing. So the ability of the HTC to achieve its objectives really relies on the diversity of representation, viewpoints, technical and financial inputs, geographical perspective, context, as well as gender. And the HTC continues to advocate for partner alignment for improved health information systems and CRVS globally, collaborating with all stakeholders at all levels, including research and academia, including the private sector, and including civil society, representing the very communities that we serve and ensuring we leave no one behind. Thank you. Back to you, Dr. Azza.
Thank you very much, Monia. That was really comprehensive. Now, before we conclude, I'm not sure if we have any questions from the floor. If this the ESCAP Secretariat, I don't see any questions in the chat, but we can give, I think, 5 minutes for questions, if necessary.
Yes. Just one or two questions. So I see someone raise his or her hand. You can please ask your question. Thank you.
Thank you for giving the opportunity. I'm Sandhya Singh. I'm Deputy Registrar General from India. So I thank all the speakers for enlightening us on the specific points about the integration with the health system. So I don't have a question, but some small comments I would like to speak in reference to India. So India, what we have done is with integration with the health information system especially, we have been increase the registration of birth as well as death in both the cases. So starting from 86%, we have reached 92% in birth registration, and similarly around 92% in the death registration as well. So in fact, in few of the states, what we have done, we have integrated the registration process with the pregnancy itself, like one of the program, RCH program is there. So we have integrated with that, wherein even from the ANC status of the lady, the health process is going on, and as a result, and the end result, they fulfill the task of providing the birth registration to the child the moment the child is born. Even linking it with the immunization programs, we could achieve milestones in many states. For example, in the state of Uttar Pradesh, who is majority of, it's a very populous state, consists of around 16% of the population of the country. So there, the entire system is being led by the health department, and in a very short period, I should say, during the last 2 years, they had implemented the CRVS system using the health facilities, linking it with different health benefits, and as of now, they could achieve 90% registration of birth as well as death. So that way, I would simply say that linking with the health would basically coordinating all the efforts of the CRVS and also taking up the agenda forward will definitely help achieving taking everyone in the picture. Thank you.
Thank you very much, Madam Sandhya. And getting an example from the civil registration system to support the health sector is really excellent. So this is how it works. All the sectors involved in the CRVS systems should support each other, understand that there's one sector cannot function without the other. Thank you very much for your intervention. So do we have other interventions from the floor? Can you see any, David? I cannot see from my side any hands up.
I don't see any. I know we had a few questions in the chat, but unfortunately, I think we need to conclude the event now so that participants have the time to join Kudo and test their connection for the official part of the event that will start in 20 minutes. Thank you very much.
Okay, excellent. So many thanks to all the speakers and all the participants, and looking forward to seeing you in session 3 of the official segment, which will start in less than half an hour, in 20 minutes. And there, the role of the health sector would be discussed again more fully with the country representatives, and also with WHO and vital strategies. But before we conclude, I leave you with take-home messages. 2. 1, improving health sector notifications and universal civil registration for universal health coverage. And many thanks to all. And have a good day. Bye-bye.
Thank you. Bye.
Bye-bye.
Thanks, everyone.